us in Africa, if it's not broken, don't fix it.
Yes.
So in everybody's minds, I'm okay, I'm fine, and they keep running and they don't know. We don't have the maintenance culture, whether it is about our cars, about our bodies, about our buildings, anything else.
Yeah. Gone are the days where we went to the hospital because we were suffering or we had a symptom. So today we want you to come to the hospital or probably anywhere we are doing screening for the purposes of prevention. Yes.
So yeah, you realize the fear is there and it may be genuine fear. But again, you rather have something caught early and prevented or reversed than having a complication.
Yeah. Screening in its entirety, for people to say this is the screening test for this disease, it has to be cheaper.
Yeah.
Screening is not only for the 18 and above, even children. We screen children for congenital diseases the moment they are born, hours after they are born, for heart issues, okay? Infectious issues, they are congenital things you can be born with, the gonorrhea, the syphilis, and all those things. So we try and screen them as 10. So it depends with what you're screening.
So you take your car to the garage and all you want is simple service. Change the oil filter, air filter, and the oil itself, of course. And then they bring you a list of things that you should have checked. Oh, your fuel filter has problems. Oh, your suspension has problems. And then on top of that, the car is not even yours. Right. Should you have taken the car to the garage? Well, how does that apply to you? We're going to find that out on the Med Squad podcast as the people who will receive you as the car are right next to me. Introduce yourselves, please.
Thank you, Yafesi. My name is Dr. Flavia Bagatya and I'm a medical officer.
Welcome.
And hi, good morning. My name is Uche. I'm a pharmacist.
Welcome.
And thank you, Yafesi, for having me here. I'm Antony Ndegwa, a general medical practitioner, passionate about management of cardiovascular diseases and non-communicable diseases.
So you're already setting your box so that we don't ask you the other question. That's fine. They've introduced me. I'm Yafesi Mosoke. And we want to find out about our bodies and the fear that people have to do with medical checkups and screenings. So obviously the first thing is why people generally don't come for checkups. Now, one of the reasons is cost. What do you say about cost? Is that a reason not to come for a checkup or to do medical checkups? Or is there something else that you have experienced with regard to reasons people don't come for checkups or don't do medical checkups?
Cost is more of a perception because you find generally these medical checkups are affordable, especially in the government facilities. And then here we have the universal health coverage. It covers that. So you find it's affordable, quite affordable.
But what about the other cost that is rarely spoken of, the opportunity cost? Because now, of course, the affordability of the government facility means a lot of people will be there. And once you go there for a checkup, that's 5-6 hours. That's the perception. So these are people who work mostly on daily wages.
Well, I think I'll bring another point to that as opposed to opportunity costs. I think for us in Africa, if it's not broken, don't fix it.
Yes.
So in everybody's minds, I'm okay, I'm fine, and they keep running and they don't know. We don't have the maintenance culture, whether it is about our cars, about our bodies, about our buildings, anything else.
Yeah.
But going back to what you said about opportunity costs, that's the thing. It's a long-term game. You don't think about, just right now, if I can pay this and then suffer through this payment or this cost right now, it's going to give me a lengthened time and then to experience and enjoy life. Going forward. But
and that brings up also the issue of if it's not broken, of course, don't check it, don't fix it. But then there's the fear and the denial. And so if I find, I have many issues which will increase the cost. So that's also kind of
gives you anxiety.
Yes.
But like I said, long-term game. It's how can I fix this right now so that I don't get to fix it at a much more higher cost later.
Yeah.
We don't think that way. We just think of, okay, let's leave it. We pray, hope that it goes away.
Yeah.
Then it now gets worse as we wait.
Which brings the cultural element. Yes. And superstition. So if I go for a checkup, I'm inviting sickness. I know Antony likes talking to people who come with those kinds of thoughts.
Okay. So first of all, screening is a very important medical aspect, and we can trace it back to the years of 1950s with the establishment of things like pap smear that has been very instrumental in reducing the death and mortality associated to cervical cancer in women. So we can clearly see that screening is very important. As we've talked about the issue of cost, of course, there is some cost associated with it, but you cannot compare it with the long-term effect of the disease and the cost implications associated with that. So on the cultural element, okay, as Africans, some people will think that probably when I, for example, go and test for a certain disease, if I don't know about it, then I'm better off. And that is very far from the truth. Anybody who gets a diagnosis, there is the stress associated with that. But over time, you get over it, and you get the intervention for the disease, and the quality of life improves. Okay? So the fact that you do not know about a disease and it's in you do not halt its process, called the disease process. So the disease process will still take its course with or without your knowledge. So screening is paramount.
Yeah. But now then that brings the issue of my lack of knowledge about something. So if it's not broken, I don't feel anything. But there may be basic or simple warning signs. Are there simple warning signs that I need to look out for outside of regular, let's say I do actually regular screens and I have that discipline, but are there other warning signs I should look out for and say, this is something I need to have checked or screened?
Yeah. You see, the body warns us in different ways that it's not okay.
Yes.
You can get something out of the norm. You can get a headache. It could mean something else. You could think it's just a normal headache and it's not.
Yes.
Could be having hypertension or a pending stroke. You can feel fatigued all the time. And then you think it's work or you changed your sleep patterns and yet it's maybe diabetes setting in. So there are different signs and symptoms to look for. We can just make it simple and say anything that's out of the ordinary.
Yeah.
Go have it checked out.
Okay.
Yeah, Yafesi, just to add on the same, just to put it into context, prevention is divided into different categories. There is primary prevention, secondary, and tertiary. So primary prevention is you preventing the onset of disease, washing your hands, cleaning your food before you take it. That is primary prevention. Then there is secondary prevention. This is now delaying or stopping the establishment of the disease.
Yeah.
So you're talking about screening now. Screening means is the process of identifying those people who are apparently normal. So probably there is no symptom that you're experiencing, but you just walk into a hospital and get your blood pressure checked and look at your BMI and do imaging, do breast examination, but you have no symptoms about those diseases. So that is screening, okay? Which is secondary prevention. And then there is tertiary prevention, where now you're already sick, you have a diagnosis. So what are you trying? You're improving the quality of life and also delaying complications. Think of somebody with hypertension. They already have a diagnosis of hypertension, but we have to delay. We have to prevent stroke, prevent kidney disease. So that is tertiary prevention. So as much as we don't have symptoms, it's not gone are the days where we went to the hospital because we are suffering or we had a symptom. So today we want you to come to the hospital or probably anywhere we are doing screening for the purposes of prevention. Yes.
Well, maybe you have real examples. Okay, you do, but can you please share some where maybe someone came for either a medical camp or something? They might even have been bringing someone else, and then they discovered a condition that really needed urgent attention without knowing that it was there.
Okay, so most of these people, you find them incidentally when somebody has just come for something else, but in the process of the consultation, you pick up something. However, most of the times, through the public health actions, like the intensified case finding, that was very strategic for TB, you find that you ask somebody some specific questions. Any patient who comes into a public hospital or even private, you have to ask them some questions. For example, are you having fever, cough, chest pains, night sweats, and all those difficulty in breathing and all those things. And it is through that we are able to get a lot of TB cases back then. And it revolutionized how we were approaching to TB. And today you can see that the management of TB is very streamlined because we've been able to get those people in the society and treat them effectively.
Yes.
So I'd say one of the exposures I've had with screening is with TB.
Yeah. Okay. Any of that? Have you also?
So we once went for a wellness, someone's home. They invited us they just wanted to do a normal checkup. They had no symptoms, they're okay. We're just doing it as routine. So we did everything, examination, history taking, and then we took off some tests. Only to realize they were hyperglycemic. Their blood sugar was above normal. But it was above normal, but not to the extent of diabetes. So they are pre-diabetic. So here we help them in a way that we're able to get it early. And then we gave them advice to change their lifestyle, to start doing exercise, to start eating healthy, to prevent it to go into diabetes. And this state was reversible.
Yeah.
So if they followed what we told them, they could go back to normal. So it was.
Okay, to add on that, so of course, in some cases where, let's speak on the women's health side, because some women, of course, we carry a lot of stress in our bodies, like we'll talk about later. But you're coming for maybe routine check, maybe you go to check for your hypertension, diabetes, and then the doctor says, oh, let's do some other female-related tests or screenings, and you find maybe you have a lump in your breast. And luckily for you, maybe you caught that early enough because there's probably some history in your family of breast cancer. So that's why we say screening also for women is also at some certain ages is very important to focus on. You might just think, oh, I'm fine, I don't feel any things, any issues, but we also have to factor in family history.
Yeah.
As well as thinking about, is there anybody in the family that had any of these? That should also give us some kind of awareness or information to actually help us go seeking for the screening and also being aware of our bodies and potential issues that it may have.
All right. Well, so you've heard about ages being mentioned and you've heard the word screening a lot. But what exactly are you screening for? You're going to find that out as we come back on the Med Squad podcast.
Hey there! Welcome to Zuri Health HQ, where Africa's finest medical minds meet modern care. I'm Yafesi, your host on the Med Squad.
Hair care is personal. It's not just diagnosis, it's direction. From a cough to managing chronic illness, we listen and we lead.
Every symptom has a story. We listen, explain, and act together.
Nutrition is not just about food. It's fuel, it's healing, it's prevention. We help you eat with purpose, for energy, for recovery, and for lifelong health.
We are not just lab coats, we are detectives, and your blood speaks when we translate.
Your mental health is not a luxury, it's your health, period. Whether it's trauma, depression, anxiety, or even wanting to speak to someone, we are here for you.
At Zuri Health, collaboration is our strongest prescription. We connect expertise across Africa to deliver care that is smart, affordable, and people first.
This is the Med Squad. Real conversations, real health, real people. From your inbox to your bedside, we're with you.
Welcome back to the Med Squad podcast. On your screen as we talk about screening. See what I did there? Okay, so anyway, I have the Med Squad with me and we're going to talk about what exactly you should be screening for. So I have Antony, I have Uche, and I have Flavia, bringing you the knowledge and the credible information because I want to go by age group first. So when we start, let's say 18 to 30, because I don't want to, the minors, I think that one is kind of, they're taken care of. But 18 to 30, what specifically are we looking for? And does it differentiate between male and female? Are there different things that women should be looking for and men should be looking for between age 18 to 30?
I'll first generalize.
Okay.
So between ages 18 to 30, we're looking at some screening for HIV, STIs, then the blood pressure. Mm-hmm. Because, nowadays, non-communicable diseases are coming to are starting early in years. So you see, people ignore this. They think someone is young, they can't have hypertension. It's only for the people who are old. But there's primary and secondary hypertension, and secondary hypertension is common in the young people, caused by different. So we're looking at hypertension, we're looking at diabetes. So when you put it in, when you become specific in 2 ages, for women from 25 years, we should screen out for HPV virus that causes cervical cancer. So we do the pap smear, you do the pap smear. And you're supposed to do it every year to screen out for the cervical cancer. Then, yes, you also look out for breast cancer. So you do a self-breast examination. If you don't know how to do that, it's better to go to a health facility. They can do it for you to screen out for breast cancer. But then also in that age group, that's the reproductive age group. So before marriage, you have to screen out for sickle cell disease. It's mostly common where I come from. Because you could both be carriers. You don't have symptoms. You're both normal. But then you're at a risk of having a sickler.
Wow.
I'll pick up on that age group. And kind of make it more focused on the part that we want to talk about, which is the sexual and reproductive health area. Because that is where the younger people start having sex. They are not aware of the risks that it can get. They're aware of the STIs that are prevalent. They're like, oh my God, I'm having fun. But you have to be able to screen for those sexually transmitted infections and diseases. And also just to be sure that whoever it is you're getting, you are protected. First of all, use protection. That's what, first of all, I have to say that. But in those cases where kids or the younger ones are not well informed, they have to screen for that. And we have to make it a destigmatized issue in society. Because, and that is why they don't go for screening, we'll come to that, is also because of stigma. They don't, I don't want to go for this because they'll know I'm having sex. But I think, especially for the girls, and the girls especially, at this stage, at the age group, we should also focus on that. And teaching them about their bodies, teaching them what to expect as they're getting older, their bodies are changing, what kind of symptoms, what kind of signs they can be aware of to actually go for the screening. So in that age group. So I'll hand over to you. Anything else to add to that?
For the gentlemen, is there anything for the gentlemen to look for?
Okay, so I would want to approach screening from a public health point of view, where according to WHO, you want to screen for, number one, diseases with a public health issue, probably burden. We're talking about communicable diseases and non-communicable diseases, okay? So you realize that non-communicable diseases, for example, cancers, both in men and women. So we're talking about colorectal cancers. And remember also, the type of disease determines what you're going to do. So are you going to do a blood test, a urine test, or an imaging, okay? So for or even clinical evaluation. You can be clinically evaluated for depression. It's screening because you came thinking I'm having issues, but I don't know. Okay. So it could be clinical, it could be imaging, or it could be a blood test or a specific test. Okay. So from men, we are talking about the prevalent cancers. We're talking about prostate. People do PSAs, others will do ultrasounds, okay, for the prostate. We are talking colorectal cancers where they do fecal or cut blood. So they're looking at blood components inside the stool, okay? For women, it's the pap smears. And just to add on what she said, for the Kenyan setting, I guess with the WHO guidelines, the pap smear are done after every 3 years. Of course, in fact, even the latest cancer screening guidelines for the Kenyan practitioners is the best to use is the high risk human papillomavirus screening. But if not available, we do the pap smear. Pap smear is after every 3 years if you are okay. And then human papillomavirus testing is after every 5 years. Okay. And that is determined again by the age group. However, the other diseases like, for example, TB, you can still screen for TB for patients at high risk. Think about people with HIV. Okay. Screening is not only for the 18 and above, even children. We screen children for congenital diseases the moment they are born, hours after they are born, for heart issues, okay? infectious issues. There are congenital things you can be born with, the gonorrhea, the syphilis, and all those things. Yeah. So we try and screen them as 10. So it depends with what you're screening, of which you don't want to walk into a hospital. You don't have all the finances. So it is very deliberate and should be guided by a reasoning behind it. Why are you doing this and not that? Of course, family history is very important. Yeah. And remember, as a client, you already know your history than the doctor. So you know, my father is diabetic. So probably doing a HbA1c is very important for you than doing other tests, okay? Yeah. And think of mammograms for women, for breast cancer. These things are life-saving.
Yeah. So we've talked about, we were focusing 18 to 30. Yes. But now if you're going 30 to 50 and 50 plus. Yeah. So, I mean, there are some that across ages need to be done. But are there some that you can only do after a certain age, like say either 50 plus or 40 plus?
You see, with the disease burden today, there are diseases that cut across. Okay? You're talking of what diseases should I not be concerned at old age? For example, people at the age of 64 and above, we unlikely do pap smears for them. Okay? So it is what disease should I not be concerned? Yes. It's not what disease I should be. You get the point? So, because if it's hypertension, anybody can get. So it's public health directed or approached, and also very, very specific in terms of your family history or underlying comorbidities. So if I have hypertension, the guidelines say I should do a kidney function test every year. Why? Because I'm at higher risk of developing kidney disease. You get the point? Yeah. So it doesn't matter if you're 35 or 60, you still need to do those tests. Okay? So it is very personal, as much as we might do some things based on, remember, screening can be individual or public. So if it's individual, then it has to be very personalized based on your history, existing comorbidities, even the finances. Yes. You see, you can do, for example, let's talk about a 45-year-old man who wants to do a prostate screening. They can afford to do a PSA, prostate specific antigen, from a blood test. That's better. But some people don't have the finance to do that. Probably they can do an ultrasound, but it's not the most recommended one. Again, there is digital rectal examination, which is also another method, as much as it's associated with stigma and it's people don't...
Digital rectal examination.
Yes.
So like you do it by Zoom. What is this?
Digital is a digit, so it's a finger.
Yes. Oh, that digit.
Yes.
Get to know your doctor.
Get to know your body part personally.
As Africans, we are... most of the young people probably, and men and the society has demonized that practice. But it's even in terms of its efficacy is as good as other tests we do. So for the old, from my experience, the older people who already have prostate issues, they have no problem. And sometimes you see lab tests that they are as good as the one interpreting them and the lab you're doing it from.
Yeah.
But if your prostate is enlarged and it's deformed,
yes,
and somebody who understands how to do a digital rectal does it, then they're able to point you in the right direction. So it's still a screening test, as much as we don't like it, but...
I saw what you did there. They're able to point you in the right direction. But talking about affordability and like where to get it done locally, there are many tests that have been listed here. There's so many things.
Yes.
And some of them you're saying they're repeat tests, so either annual or every 2 years, every 3 years. Are we really knowing that insurance penetration on the continent, or at least in this country, is very low? So that actually does contribute to the reason why people don't do screening. So is it a perception? Or are we sometimes taken advantage of? Like, you go to this person, they have shares in this facility, so they keep sending you for scans and tests and all that. So where is the safe space? In whose hands are we safe as patients?
But I think for screening it should, like we said, there are different levels of it: primary, secondary, tertiary screenings. So by the time you start to the first two, primary and secondary, it's pretty affordable. It's doing urinalysis, which is cheap, but quite affordable for that. Quick, simple blood pricks to check your blood sugar. You do a VP measurement for your. It's not expensive. Those are things that can be covered. You can do it every month, which is actually cheap enough to do. But that's why we say is actually having enough knowledge to start early. Because if you don't start early and you start having screening at a tertiary level where there are already symptoms, yes, you can expect it from then. But I think that in most of the public health institutes, in most of the clinics and all that, you just can't walk into a hospital or walk into a pharmacy even to check your blood pressure, which is pretty, I think they don't think charge for that, so that's cheap. So people shouldn't have that idea of, oh my God, it's expensive. You have to actually come with the idea of, like I said, the perception. And also I think it's public health, like tell your friends, I did this here, oh, you should check as well. Oh, I did this. So it's also knowledge being spread about and awareness. It's not just to say, I went here and then I don't want anybody to know. It's like, I think public health is communal. It's for the public. So you also have to help each other and then make sure that you're able to get these screenings done when as early as possible. Then for affordability, we'll speak of that as well. And you said about insurances that are being covered. I think that at least most of them, because screening is just one half of it. They have to have diagnosis, they have to have treatment.
Yes.
Screening is the least expensive, is the most affordable. So why don't we start with that first and start worrying about, oh my God, what am I going to do when I need to do treatment? So I think it's about awareness, about the perception of the people, and also it's really about the medical team. How receptive are they of the patients that are coming for screening? If there are also issues of that, if I come to you and say, oh, I think I want to get this screening done, and a doctor says, oh, you're fine. Let me give you an example. Someone says, oh, I want to check up on maybe my blood sugar or my blood pressure. I said, but you're slim, you're fine, you're doing okay. Why need to check on these things? That's another way that people now go, okay, the doctor said I was fine. Or there's this idea or perception that people have that I should be okay. So I go around without thinking that, that's another lane to it, but we'll discuss about that later. But let's focus on actually the screening itself and affordability, and if anybody has anything to say about affordability.
So, okay, first of all, just to put it into context,
yes,
screening is not diagnosis. So it means if you do a screening test now and you find it is abnormal, then you're required to do additional diagnostic tests.
Okay.
Get the point?
Yes.
So screening in its entirety, for people to say this is the screening test for this disease, it has to be cheaper.
Yeah.
Okay.
Yes.
So if you walk into a hospital, the guidelines-based clinical practice, there is a screening test for specific disease. If there is none, then there is a clinical criteria of which you have to meet for you to be at higher risk of, or probably a patient, we say, probably the doctor thinks you might be suffering from that disease before they send you for that diagnostic test. So screening should be easier. Think about taking a blood pressure measurement. How much should it cost? Think about sitting down and filling up a depression form. How expensive is that? Okay. Think about doing a BMI. Okay. You get the point.
Get a free blood pressure if you say I'm coming to donate blood.
Yes.
Or something.
Yeah.
So screening it should be affordable. That's one. So the other thing, issues of access, meaning availability and affordability, are an issue in Africa in general in terms of healthcare. But we are doing good. At least today, blood pressure machines are not just medical equipment; they are at homes. So we are getting there. And as we continue sensitizing on the importance of screening, I guess things get. So you're thinking of other areas where they don't have even machines to do full mammograms. Okay. So, but at least we are getting there. So with the insurance also, it's more of policy. And you can see even, for example, the Kenyan government tries to come up with insurance policies that work for the most basic healthcare needs. So I think we are getting there.
You're getting there.
Yeah.
We are getting there.
Getting there everywhere. There's always room for improvement.
Always room for improvement. Now that the tech and the facilities are there, even for domestic use, what are the myths that are keeping you from getting your screening? We're going to find out about those myths right here on the Med Squad podcast when we come back. Welcome back to the Med Squad podcast, and we're talking about screening. When was the last one you did? No, seriously, I'm waiting. Okay, drop it in the comments. I have the Med Squad with me, and some of the myths that we hear. Of course, the whole thing with screening is the image. Maybe you've been watching too much ER or House. And so there are these big machines, scan this, scan that, and these beeping sounds. So it's for rich people, and which includes people who have insurance cover. So yes, we've already kind of touched on it, but there are also those ones who have either religious or cultural beliefs or superstitions that prevent them from going there.
So going back to my initial statement of if it's not broken, don't fix it. This is the kind of mentality we have in Africa. Then we layer on the cultural and then the religious ones, of course. So there's a thing of, oh, my father never had this, so why should it be my family? Or we say, oh, it's not my portion, that, God did not portion this to me. So all that is that all layers that actually make people decide not to either go screening, or there's that fear of, let me not find out something. But I think we need to change that perception. We need to also look at the long term, like we say, how good are we living our lives? How long are we living the lives? Is it actually, even though the idea is they live longer lives, but is it well? Is it actually something impactful? Yeah. So this is where we now tie it into, try to make it very as simple as possible to educate people. It's not about that. Don't be scared of that. This is just a simple way to ensure that you actually have a stronger, healthier life. Screening is very important. That's the basis of it. And that's why we're trying to infuse it into every little aspect. Whether you come to the pharmacy to buy a drug, I talk about screening to you. If you come to the hospital to get something, maybe if you come with your friend, we also have to find a way to make people aware that it's okay to screen. It is very good to screen because, like I said, it is very preventative. You want to be able to catch anything you think or anything that might be going on in your body early enough. So it's also going to help you prevent spending more money in the future. So I think that's the myth or perception, but we're also trying to dispel that myth or those myths and then make sure that people are more, encouraged to do this.
Uh-huh. Also, there's the other issue of course, I'm afraid they'll find something, just the same way with the car. But it seems also skewed a lot towards men. Mm-hmm. Men, there's the fear, but there's also shame, sometimes pride. It's just toxic masculinity, like, tests are for wimps. Yeah. So how do we address these ones?
You realize the fear is there, and it may be genuine fear. But again, you rather have something caught early and prevented or reversed than having a complication. Yeah. So it's actually better you outlive your fears, and then you can find out.
Yeah.
Yafesi. Let's maybe break down and see what happens when the disease gets into your body. Mm-hmm. So I want to take you back in the 1980s in America. So there were clinicians, doctors were seated in their offices. And then men were coming with complaints of chest pain, cough, difficulty in breathing.
Yes.
The doctors would look at them and they were like, this is pneumonia. And they were given medication, of course, antibiotics. They went home. These patients were not getting well.
Yes.
They come back to the doctor. Oh, I'm still having chest pain. I'm not getting better. So over time, the doctors or the physicians realized, it's a group of men. Mm-hmm. They said, these people are not responding to our medication. So what do? Let's try and maybe follow them up. Mm-hmm. Study the cases. So they followed up and they realized, majority of these men were gay men. Mm. They still followed them. There was no intervention for them. So they followed them. In the first month, they were just having chest pain, lymphadenopathy and all those things. It turned out it was HIV. So the doctors did not know if it was HIV. The victims did not know it was HIV.
Yeah.
The disease did not care. Still continued. So chest pain and all those chest complications could be TB, could be something called Kaposi sarcoma.
What?
Kaposi sarcoma or visceral Kaposi sarcoma.
Yes.
Or some pneumonia which is fungal called pneumocystic pneumonia.
Yes.
You cannot manage it with antibiotics, like the conventional pneumonia. Don't get well, okay? Could be all those. But we see from that story is that the fact that I don't know about it, it does not hurt me. That you should dump that statement. It's not true. Because the moment pressure is in your body, the fear of taking that blood pressure and seeing it's high, or not taking those medications that you think you're going to take them for life because that is what you've been told, it does not change the natural cause of the disease. So screening is very important. We are all candidates for any disease. So that's why we are saying, just get over it, do that test. And it's normal or it's abnormal, you get the next, they help you because there is help. There is hope in getting that screening done. However, if you don't, then you can't fight your enemy because you don't even know the enemy. So that's the problem. So for men, it is time we just rise up. The health-seeking behavior for men has always been low. There is no toxicity against a disease. You cannot be toxic against prostate cancer. You cannot be toxic about HIV or any disease. So just screening.
Just screen.
Just screen.
So picking up from what you said, there's also what we call disease progression. So a disease starts from the initial stages, then it goes to maybe stage 2, then complications. So the earlier it is caught, the better outcomes for you, and then also the more money you're saving. And then also you won't be admitted. Yes.
And which will cost you more. Now, which brings me to another thing. Generally, the medical profession is celebrated, especially at the academic level. So high school, you're going to be a doctor. Whoa, Then you get all the good grades and everything, go graduate. Oh, now you're a doctor. The title is there. Until it's time to actually see you. Then there's a distrust. Like,
it's not really distrust. You just don't want to hear bad news. You don't want somebody to hear bad news to you. So the whole idea is that doctor will tell me there's something wrong with me. It's an idea of, if I go to the doctor now, he will tell me there's something, this is this, my back is broken, I have this disease. And there's the fear. So that's where the anxiety and fear comes from again. It's just a case of, do I want to hear this? It's bearer of bad news, in quote. Yes, I think that's the first idea. They like the idea that you're a doctor, yes, but don't try to use your practice on me. So I don't find something wrong or you make me seem like I'm not doing my best. For example, if you see a doctor and the doctor says, oh, uncle or daddy or sir, you need to stop drinking alcohol. You need to slow down. But that's what you do every evening. That's your vice. That's your poison. You don't want to hear that. You don't want to hear that someone's going to take away that thing that you like just because it's going to affect your health. So you start sneaking away, dodging the doctor. Say, oh no, I just took 1 bottle yesterday, I'm fine. But maybe you took like 5. So it's not distrust. It's just that fear of they're going to put you on the spot and make sure that you do good, as opposed to, we don't want to do that change. Or we don't also want to have to go through that painful process of trying to change, do a lifestyle change. So we try to hide away from that. That's one part of it for the men as well.
There's also the element where not everyone gets into a profession for the same reasons. For some people, it doesn't matter whether you pay me or not. I'm passionate about this. I love this. I want to help people and all. But the others, who will send you for all the scans at a specific facility because they have shares in that place. There have been people who have misdiagnosed, whether it's because of negligence or whatever it is. It was like the way you mentioned someone who looks at you and says, no, you're skinny, you're fine, you don't. So could that also play into that?
Yeah, of course. I think it did. I think it does. But also we don't have to, those are the small percentage or small perception of it. We don't want to make that the big thing. We just want to focus on how best within a community.
So this distrust could be also a perception that some people are greedy. Yes, there may be a small percentage, but it does affect my approach to screening and healthcare. How do we go around that?
How do you go around that? I think I'll pass it to Antony to handle that because I think he has some key points for that.
So, number one, the delivery of news about a diagnosis or a screening outcome has to be honest from the doctor's point of view to the patient. So the relationship, the communication has to be professional and honesty must be there. So despite having done that prostate specific antigen and it's 10 and the doctor thinks, so high, could be cancer,
Mm-hmm.
but it could be something else because that is not diagnostic. So the way I deliver the news to the patient determines their response. And that's why a lot of patients out there will blame us for not taking the test, because we burden them with big terms and big diseases. And if you come to really think about it, if you deliver the news properly, then the patient is receptive.
Yes.
So for example, let's give an example of prostate cancer. So if you do a PSA,
Mm-hmm.
and let's say it's above 4 and 10, you're thinking it's an abnormal test, but it's not specific for prostate cancer. So if you tell the patient that there is likelihood that you're having cancer, without telling them there is need to do other tests, you put the patient through a lot. And then they go and do the other tests, and it turns out they had prostatitis, an infection of the prostate. Will they ever come again to do those tests, those screening things? No. You took me through hell for 2 weeks before I did the other test, probably looking for money or doing or whatever, or getting a proper diagnosis, just because of you as the doctor. So we have a role to play in terms of how the public responds to the screening calls, or generally the hospitals. People don't want to come to the hospital because you go there with a headache, and then, of course, it could be hypertension, but how you're told about the hypertension, now this is a death sentence, there's no hope for you, you will take medication for life. If you don't take your medication, your brain goes kaput with stroke, where you're going to lose your your sexual performance, your wife is going to go out. You get the point? So that kind of information makes the public to be, let's say, fearful of the screening. They just prefer to stay at home with their peaceful. Remember, health or wellness is not absence of disease. You can have a diagnosis, but you're well. You've taken your medication. If I take your blood pressure is normal, unless you tell me, Anthony, I took my blood pressure pills in the morning. But there is that other person who does not have a diagnosis. Having gone to different hospitals, doing all the tests, they have insurance, they can afford, but there is no diagnosis for them. So are they healthy? No. You get the point?
Yes.
So having a diagnosis does not make you unhealthy. Okay? So don't fear to get that screening test done.
Just one more thing to add on to that. He's talked about the doctor-patient communication angle. Now, the other part is the patient-doctor. I think we don't ask enough questions. Quiz your doctor. Don't ask. For example, think about it as someone takes your money from you. You find out with the person the money, how much the person took, how much the person is owing you, how much that you know all the things you need to do. But don't just go to the doctor and expect him to tell you everything. No, ask him questions. Okay, challenge him. Okay, what do I do here? If this happens, what do I do? How do I handle this? It's called patient advocacy. Advocate for yourself as well. I think that's something that we just take the news and just like, oh my God, they said and then they're quiet. What do I do? If this is also, you know yourself better than the doctor.
Yeah.
You know your body better than the doctor. Don't worry about doctor telling you what to do. Tell your doctor, no, this is what I think. Even if it might sound foolish at first, but the doctor will have to listen to you because he has to treat you.
Yes.
So I want patients to also be bold enough to ask the hard questions, push back, because doctors see how many patients a day. So there's also that thing of they just want to just give you diagnosis and let you go. But if you actually sit them down and say, no, explain it to me, walk me back, they are now, more aware of you. They are more focused on what you need. They're now, this person is actually serious about taking their health seriously. So they actually have more poignant answers or points for you to be able to handle your health better when you go.
Do I know myself better than my doctor?
Yes, you do.
Antony.
Yeah.
So also, speaking from a doctor's point of view, that's why screening should come hand in hand with counseling. Because with counseling, you're preparing this person for the news. You're preparing them for the diagnosis. By the time you give it to them, they already know what it is. They already know how to take care of themselves and how to handle the condition.
So it also helps you prepare for the emotional lifestyle change and all that.
Okay, before a patient takes a test, you know what you're screening for, right?
The patient,
for example,
or the
if you come to me and tell me, Anthony, I want to do some screening.
Okay.
When I put a blood pressure cuff on you, we are looking for nothing else other than hypertension. Okay?
Yes.
So when we get that value, I am the one to make it make sense to you that one reading is not diagnostic of hypertension. We have to do 1, 2, we have to do journaling. You get the point? If we do, for example, a prostate, or let's talk about a pap smear, that test does not come saying that you have cancer. Okay? So that is a preparatory statement to tell your patient that whatever we are doing is not specific or sensitive for a diagnosis.
Okay.
You will have to do addition. For example, if a pap smear comes out abnormally, we might need to do a biopsy. And that the biopsy is the one that is going to say, now you are sick.
Yes.
Okay? But just to add on whatever she had said about questioning your doctor, the question I'd want to put across is, even when you have a diagnosis, let's give an example of, let's say something like ulcers, or maybe probably something infectious, like let's say pneumonia. So the traditional way is you go to the hospital, you get tests, you talk to a doctor for the consultation, they decide what test to do, and then you go do the test, then you're found to be positive of that disease, and you're given medication. Away from long-term illnesses, these ones you're going to take medication for probably a week, 5 days, if antibiotics, or 2 weeks. The big question is, what do I do after this medication? And that is now the primary prevention. Because if you got a diarrheal disease because you ate from somewhere, you can get reinfected. You take the medication for a week, you're good, you walk around and you go back. The same with UTIs and recurrent and reinfectious. You don't ask your doctor, what do I do? And the doctor will not tell you, so that you come tomorrow. You get the point? So for those who are there for the money, they don't have the time for that. They have the time for prescription. Then you go take the medication. And then I know you will come back because you don't know where you got that bag from. So you're going to get it back and then you come back.
Oh, man.
So the information is more important. So the first question is, doctor, what is wrong with me? I have given you all my stories. Everything about me I have given you. What is my problem? The doctor should be frank. I don't know, or this is what we can do, or probably this is what you are dealing with. And these are the options. Not that I should not make a decision for my patient. I tell the patient the options on the table. So if you're having, for example, a cough, one option is it's self-limiting. It will go away. So there's nothing we are doing. How many times have you walked out of the hospital without a prescription? Most of the time you come out with drugs. So that is the first option. The other option is there is medication to relieve symptoms. Okay? And the patient chooses, I want to go and deal with my problem. Let me trust my immunity. Or give me your medication so that I can ease it. And that's how the practice should be.
As a pharmacist, yes, I have those times where I see a prescription and I'm like, what's wrong with you? And I actually have to go back to the doctor and say, I don't think we need all these prescriptions. And we need to actually do some lifestyle changes. We have to do some ways, some kind of support to the patient. The patient doesn't feel overwhelmed, because even though I'm a pharmacist, I'm not so big on just give medications at once. You have to start from, because medication is the last resort. It's basically, medicines are basically a poison, just a little bit of poison. But so how do we actually find ways to reverse it? Lifestyle changes, what kind of things can you do to actually help? Because a patient is only going to get better if they feel supported and they can handle things by themselves. They should be dependent on the medication, or dependent on doctor. You should also be able to, if the doctor is not there, I can take care of myself because I've been given enough information, enough support by the medical practitioner that I've seen. And just to help them with a better outcome and live longer and happier.
All right. When we come back, we'll be finding out how to not overwhelm the doctors right here on the Med Squad podcast. Welcome back to the Med Squad podcast, where prevention is power. At least that's what I want to just put out there. As we've been talking about screenings, as we're coming down to give practical advice, first we've mentioned how the importance of early detection, and also definitely the community culture. How we're trying to empower generally as a community to remove stigma and everything. Let's actually do the screening. But what about this other element called mental health? Should I treat it the same way as other diseases that may be, for lack of a better word, more tangible? So do I do that with my regular screenings, or how do I do it? Because that one is not as easily diagnosed, I suppose.
So with mental health, as I hinted earlier, there are screening for that. So again, this is based on the background. For example, somebody has a comorbidity or an underlying condition. For example, people with diabetes must have depression screening annually. So this is based on the fact that issues of diabetes are associated with development of mental health, leave alone the aspect or the burden of living with a chronic illness. There is also a structural damage associated with it in the brain. That's why it's a leading cause of dementias and Alzheimer's. So mental health, as much as we don't go for the specific lab tests, is more of clinical diagnosis, clinical evaluation, okay? So you will ask about your behavioral changes, cognitive changes, and all those things. So mental health is as screenable as the tangible diseases we talked about.
But that's the word disease is just basically disease, lack of ease. Whether it's mentally, whether it's physically, whether it's anything, there's a disease in your body. And I like the fact that it's becoming more prevalent to do screenings for mental health, because also mental health affects everything. If you don't have a strong mental health, you will probably not get better physically, because our mind is more powerful than we think. So we have to get the mental aspect strong enough to be able to get better about other things. Because if you're already depressed or feeling sad about, oh my God, I have this diagnosis, you wouldn't actually put in as much effort to get better. If you say maybe I have cancer and you're already feeling sad about it, you will not put in the effort that you need to be able to actually do the lifestyle change your diet, take your medication, go out, do exercises. Because of course, our mind, the willpower to do it is probably low. But if you have that mental fortitude and strong mental health, of course, you can actually push through and then achieve a greater outcome than you would have without that mental health.
Okay.
And also, mental health is different from other conditions. So it's something also a non-medic can perceive. You can, you're in a work environment, you can ask someone how they are, and you can tell they're not okay.
Yes.
And you try to do what you can to help. So that's part of screening. We need to create more awareness. And people should be more deliberate about it, and also be their brothers supportive and
awareness. Actually, in line with that, speaking of awareness, is there room, or has there been successful in the past partnership with communities like churches, mosques, schools, especially religious institutions, because of there's the mental, the psychological, emotional support system and aspect of that. So like when doing, say, medical camps or education campaigns, is there room for that partnership, or do they also have, because I know there are some religions that even ban their people from going to hospitals, or some sects that ban their people from seeking medical help. So how do we do that with the room for partnership, but at the same time, beliefs that prevent?
I'll start with sensitization, awareness, talk to people. Because even at the end of the day, every human has their own will of power. So even if, yes, you're in a sect that says, okay, don't go to hospitals, but don't do all that. But it gets to the point where you know that as a person, you feel it in your body. Like, yeah, I need to get help. And at that point in time, it's you against the sector, you against a religion. But now it's, so that at that point in time, we try to help as much as we can. Give them like educational talks where this is what you need, give them support to say, okay, if you don't want to go to the hospital, what can we bring to you? Let's try to see ways that you can make changes in your lifestyle that can actually help you to support to get better. We also don't want to have that, because also there's a case of overburdening people with information. How do we simplify it in a way that it's easy to understand. It is also communal. If you get the buy-in of the community, of the church, of the sector, whatever, you get the other people.
Yeah.
So you actually also speak to the leaders to see this is what is happening in the communities, in the world. We need to educate the people. How do we go about it? You might get pushback, but over time, I think people are really willing to change and further understand how they can support their community and support the larger people at large to be able to get better health.
Okay, Flavia, you want to?
Yeah, I wanted to say that as the health system, as the health sector, we should do more to put more emphasis to collaborate with these stakeholders, with our hospital, with our religious people, with the churches, with the schools, because these people hold a certain kind of power over the community. You find someone listens to their pastor more than they will listen to you as a doctor.
Yes.
So we should hold more, to help us, especially the schools also, universities, health talks in the universities, also the tutors, the lecturers doing their part.
Yeah.
Yes.
And even the lecturer is also getting screened.
So, just to add, for me, from a religious point of view, I think churches don't do much. They just do the best in terms of giving you hope and faith. That pray and believe that you'll be okay. Remember, there is the action behind it.
Yes.
So that your faith is not dead, right? However, I've seen some few churches, I'm not going to say all of them, but there's some few churches that organize health camps, which are good. However, the insurance companies and health organizations, they really do a good job. You will see now and then a lot of camps that happen. Healthcare organization in the non-governmental organization in partnership with the government, government institutions have been really doing a good job in terms of extending these wellness and screening campaigns to the outreaches to the last kilometers in Kenya. So I'd say as much as we will need more, at least we are headed in the right direction. So whenever you're called upon to do these camps, just go.
Yes.
And most of them, they are not comprehensive. So you cannot do all the tests in the world. You'll do specifically. Of course, we said that screening is from a personalized point of view or from a public health point of view. So a group of people. If, for example, you're talking about Nairobi, what are the most common conditions around here? You'll find you're doing those kind of tests. So anytime, so for me is more of embrace those situations or those opportunities whenever they come.
Yes.
Because if we sit and say we don't do, then you might not be on the lookout. But they are there.
So you now can give you incentives. At the camp, you get free bananas, if that's possible. Also, we could actually make it a thing where we treat the screening as an education.
Yes.
And so like it's a
fun activity.
Like a qualification, like, hey, I got my BP reading, I know my blood pressure reading,
Yes,
and that's a celebration.
Know yourself.
Yes.
So Yafesi, the cue for you to do screening is not for any other person. You see, majority of why people go to the hospital, the most prevalent thing that makes people to go to the hospital is pain
and discomfort.
Okay, so pain and then some level of bloodshed. If somebody could be coughing for 1 year, but then when they cough blood, they go to the hospital.
Wow,
you get the point?
Yes.
So there is some substance to which they see and say, "Oh no, I am dying. Let me go to the hospital." Okay, but for screening, they don't have that.
Okay.
So the most important thing that will give you the motivation to do screening is your long-term health, is your quality of life, is understanding, awareness, understanding that if you do not know the enemy, then you're not able to prevent or prepare against the same enemy. So it is through those screening that we get now. We say that there's primary, of which is more of information, learning how not to be sick. And then there's screening, finding out if you're sick or not. And then there's tertiary, where you're already sick.
Yes.
Preventing complications, being rehabilitated. For example, if you have mental health, probably secondary to drug abuse, there is rehabilitation for you. And then still, there is screening for complication, even at tertiary level. You get the point?
Yes.
So there is so many reasons for you to get screened. Get
Giving
screened.
you all the ones.
But also, as we go on to create awareness, it's important to celebrate the small wins. Someone has gotten their blood pressure checked up. They can celebrate it on their community WhatsApp group. I know my blood pressure. Do you? You know, or they're from home. They live in a family setting. They come from a family setting, and let's say the dad, they know their blood pressure, but what about the wife? What about the children? So it is important. Don't do it alone.
Yes.
Tell a friend to tell a friend.
Yes.
Take your siblings with you.
Yes.
You never know.
Oh, yes. In fact, you've even given me one of my points that I was going to raise, making it even a family thing.
Yeah.
As we wrap up, there's just a couple of questions, two actually. What one screening would you recommend everyone does this year?
First of all, I think due to the high rise of NCDs, I think we can. Well, no, I will change my answer. I'll start from a point of as a woman.
As a woman, okay.
As a woman, because we women, we need to also understand that I think we need to do reproductive health screenings, like sexual health screenings.
Okay.
Do all the tests that you need to do for screenings, because sometimes you forget. Like you said, it's not like I have high BP or something. You say, oh, I have it each day or something, but do the screenings for reproductive health and sexual health. Okay. So those are the things that are pretty key, because it creeps up on you. You wouldn't know, and you know that, oh my God, someone has breast cancer or cervical cancer or something. So as early as whatever it is, or any infections, because you can have a small infection and it gets too complicated because you didn't treat it all the time. So we want to have sexual reproductive health screening, especially for women. Yes, that's my first for me.
Do you have one that you'd recommend? The one that you've been thinking about?
I wouldn't say one, but I'll definitely high blood pressure. Not high blood pressure, but you know your blood pressure. Yes. And then I would go on to say, like, for our teeth, it's something people don't do. They ignore. But the earlier you do that, the earlier you see the dentist.
Yeah.
You see, it's recommended to do a dental checkup at least once or twice a year, depending. But you see, when you go just to that dental checkup, it will be cheap. Then when you go and you have something with your tooth, you're feeling sensitivity, you're going to pay extra money than you'd have paid. And when you wait for the sensitivity to become pain, again, you're going to pay more money
Keeps growing.
for a root canal than you would have paid.
Yeah.
So get your teeth checked and then know your blood pressure.
Okay. Hey, some of us already are due a whole car in the mouth.
So for me, I would think the most important one is probably let's screen for ignorance. Right.
Screen for ignorance, yes.
Okay.
People know. Majority of people know. They understand there's need.
Yes.
Especially the modern man, let's say this society that we live in, with the rise of social media, and the how information is disseminated. 2 scrolls of 1 click of a mouse, you can know what you need to screen, but you decide not to. So I am thinking for the bigger part of people who are ignorant of their health status, it's an issue of ignorance.
Yeah.
And not to say that there are no other factors associated with cost, availability, and expertise, of course, from us as the medical practitioners, but I think it's more of taking that action and doing it. Because how many people need to do a blood pressure test? Almost everyone. Okay. Measurement. How many people need to do their glucose checks because of whatever you're going through? We are saying that the world is more obesogenic today. So probably you need to do a BMI, a waist circumference test. Like there are so many tests that baseline that as long as you are a human being and not an antelope, you must do them.
Yes.
But you choose not to. So you see, the disease is not the hypertension, it is more of the ignorance. Okay.
Yes.
And then for those who do not know, it's more of awareness. So let's screen for literacy. Okay. So it's more of awareness again. So I think the decision on which test to do is more personalized.
Yeah.
Or when the opportunity accrues. For example, Antony, if there is somewhere people are screening for all cancer markers, I will run there. You get the point?
Yes.
But I deal with BP machines every now and then. I've been doing so. You see, if you recommend that to me, you're not being helpful. Right?
Which now brings me to my final question. Leading by example, do doctors get screened? Do you do it screen yourself, or do doctors have doctors?
Yes.
Doctors have doctors.
Doctors have doctors.
Yes. So personally, recently I did my blood pressure and I know it. So for doctors too, it's advisable, but you don't treat yourself. You need to see a colleague.
You can't treat yourself. But also the hardest patients, but the most difficult patients, except practitioners, because you can't tell us what to do. We know what to do. But yes, we have doctors. He's my doctor at the moment, but we're fighting all the time.
Oh yeah.
Because as pharmacist and doctor, we're like, no, I want to do this, but we'll have doctors, and we have to know, because another thing is, it's silly for you to go telling somebody else what they should do.
Yeah.
And the patient sees you doing other part of it, the opposite of it. So it's not even, doesn't make sense. It's actually do as I do, not really just as I tell you. Because it's good to actually put in, show to the patient that this is what is happening. Also have this as well. They also feel a bit more relaxed, and then that I also have this with it. Don't worry, don't feel like I'm perfect. I'm better than perfect, but the patient understand that, look, I'm also working through this struggle.
Yeah.
So I understand where you're coming from. That also helps the patient be less anxious and open up to you more, and then the patient gets a better outcome. So yes, we have doctors, we do our screenings and do our tests and get our vaccines and all that. So
Yafesi, yes. Let me tell you something.
Please do.
Anytime a doctor has a diagnosis, all the information they have goes out the window. They behave like just another person. They'll be throwing some information about that disease. They can understand the lab tests, but they cannot make the decisions for themselves. So they require the other person. Think of a therapist. They speak to so many people with so many troubles and all these experiences. They also go for therapy. Okay, so that they don't go ballistic themselves, right? So it's very important for doctors to. However, for me, I'm always saying that it's always good to live what you preach. As a doctor, if you're telling people to reduce weight, I don't expect you to be obese. So and then if you're having hypertension, then whatever works for you. If you're telling me to reduce my salt intake, avoid processed food, be more relaxed, take care of myself, and I find when I look at you, you see, even as much as us as doctors, we can look at you and figure out where you are. Also, patients can see that. They look at you and they're like, you have reduced the weight fast. You get the point. Yeah. And let's try. In fact, with lifestyle diseases, as doctors, sometimes you look at colleagues and how they preach it and what they do.
Two opposite ends.
So you get the point. So it's all about making things practical and seek help when needed for everyone.
Yeah.
Even pastors, they are prayed for.
Oh, they are prayed for.
Exactly.
Wow. So much information in this episode. Now, if you see your doctor eating a pack of crisps, let me know about that. Yeah. If you did find any information useful or helpful, share it. Please share it, even with your doctor. But also follow us on our platforms at the Med Squad Pod. That's the handle. And we'll see you next time after your screening.